لايف. اوكي سيدي امورنا تمام.
بسم الله الرحمن الرحيم. يعطيكم العافية شباب. عارفين الوقت يعني ممكن يكون شوي مزعج، مسطلين، الكل تعبان، بس نحاول بس يعني نستوعب أكبر قدر ممكن من التوك today، لأنه إشي بتشوفه كل يوم، وإشي you will encounter it every single day in your practice. Our talk today will be about pathological fracture and metastatic bone disease. So إذا بدنا نحكي our objectives today, it will be about reviewing the system and physical exam presentation finding associated with a pathological fracture, outline the approach and staging workup for the bony lesions resulting in a pathological fracture, and explain the importance of collaboration, communication, treating pathological fracture and metastatic bone disease in skeletal related events. هسا إذا بدي واحد من الشباب، أي واحد منكم يعلق لي إيش شايف بالإكس رايز هذول.
مساء الخير دكتور محمود، كيفك سيدي؟
مساء النور، هلا والله. بس مين معي بيحكي؟
حمزة الكعبني سيدي.
إيش
سيدي نبلش من الأب left. This X-ray shows I don't know right or left shoulder to skeletally immature patient showing foreign leaf sign، يعني على الأغلب unicameral bone cyst و fractured broken.
قبل هيك pathological fracture.
pathological fracture sorry.
سكيب على اللي بعديها. أنا بدي هسه أطلع بكونكلوجن معين من الحكي كله. اللي بعديها
سير same to X-ray skeletal immature patient showing pathological fracture mid shaft femur، وبرضه في lesion proximally كمان.
اوكي. واحد ثاني غير حمزة. شكرا يا حمزة.
لا بتطور.
ساعد معنا.
أنا دكتور أحمد. الصورة الثالثة تبين بروكسيمال هيومرس وفيها ريتك ليجن وكمان فلاكشر.
تقدر ترفع صوتك بس ساعد شوي.
والله سيدي هو الصوت عندك يمكن واطي والله.
عندي واطي.
هيك سامعني؟
أحسن.
أحكي الصورة الثالثة هي بروكسيمال هيومرس فيها ريتك ليجن وفيها كمان فلاكشر، فهي مسلم كمان باثولوجيكال فلاكشر. الصورة الرابعة كمان تبين لنا ديستال فيمر فلاكشر، كمان في هناك مبين زي يعني الدنس بتاعت البون اقل، فممكن انه في ليتك ليجن كمان فيها.
اوكي شكرا سعد. هسه الكونكلوجن بكل السلايد هاي الفكره منه انه pathological fracture occurs in any bone. ممكن تكون malignant، ممكن تكون benign، ممكن تكون metastatic workup. فكيف بدك تبلش فيها؟ to introduce pathological fracture هو bone fracture بصير عندك inadequate trauma and caused by a pre-existing pathological bone lesion. Usually البون بيكون abnormal, weakened bone, predispose the patient to failure during normal activity. أهم إشي بالهيستوري إنه trivial trauma. المريض بيجي بحكي لك إنه وقعة بسيطة، أو ممكن هو بقح، هو بيسوي أي حركة بسيطة it induced the fracture. ليش مهم هو؟ إذا بدنا نحكي statistic, about 2 million people sustain a pathological fracture related to osteoporosis each year. Of patients 50 years of age, 24 of them who sustains a hip fracture will die within 1 year, and 1 of every 2 women will have an osteoporosis related fracture in her lifetime. هذا الحكي كله في US. About Paget disease affects estimated 1 million people in the United States, and 20 to 50,000 Americans have osteogenesis imperfecta. And the American Cancer Society predicts that 1.8 million new cancer cases will be diagnosed in 2019, and nearly 50% of these tumors can metastasize to the skeleton. هسا بدي أفرق بين 3 شغلات: stress fracture insufficiency fracture وباثولوجيكال fracture. هسا الستريس fracture usually fractures بصير على normal bone، بس المايكرو تروما لإله it exceeds the remodeling capacity للبون، فلذلك بصير في عندنا stress fracture. أهم شيء إنه يكون normal bone which is seen usually في military recruits.
دكتور محمود
fracture. نعم
سيدي بيرفع معك الصوت أكثر من هيك ولا هيك أعلى شيء؟
والله أعلى شيء يا ناصر، يعني بدي أحاول. هيك أحسن؟
يعني شوي سيدي. خلص إذا أعلى شيء هيك سيدي خلص ما في مشكلة.
هيك أعلى شيء. بدي أحاول هالشغلة، بس احكي لي إنه ضابط ولا لا.
أوكي سيدي.
هيك ناصر؟
أحسن سيدي هيك.
هيك أحسن؟
شوي سيدي.
اوكي.
طبعا محمود، اذا انك تحكي انت عن طريق اللابتوب مباشره او عن طريق المايك تفرق، اذا انك حاط سماعات يمكن الصوت يكون اوضح.
انا حاط سماعات والله. حاط سماعات، يعني انا الصوت عندي واضح كثير، يعني هسه صوتك حتى واضح يعني. هيك احسن الصوت.
دكتور محمود الله يعطيك العافيه. بتقدر من السيتنجز، من الاوديو سيتنجز سيدي، في الانبوت ليفل فوليوم تقدر تزيدها هاي
على اليمين سيدي، يعني السماعه
تحت على اليسار. وين الاوديو؟ لا على الاوديو سيتنجز جوا الزوم
تحت الزوم.
اكبس في سهم سيدي عند الميوت انميوت اوديو سيتنجز اخر
فوق.
وحده.
هسه بصور لك اياها سيدي. الميكروفون سيدي فوليوم ترفع للاخر، اخر صوره وديت لك اياها.
الميكروفون والله ما رافع عندي على الاخر.
رافع على الاخر هيك؟
هيك رافع على الاخر.
خلص مش مشكله سيدي، تكون هيك
وشيل
على
التك عن الاوتوماتيكلي ادجست مايكروفون فوليوم.
هاي الاوتوماتيك
شيلها، خليها دي سيلكتد هيك بضل اعلى واطلع منه اللي يعمل ابلاي.
اوكي. هيك الصوت احسن يا شباب؟
احسن يعني قبل.
اي سيدي.
اوكي.
فحكينا اخر اشي انه الستريس fracture usually normal bone. الانسufficiency fracture pathological fracture usually they are abnormal bone. الانسufficiency usually a metabolically weakened bone، بينما الباثولوجيكال fracture usually it is induced by malignancy. هسا مجد, what do you see in this paragraph?
This is the Young's modulus of elasticity for bone. هون كونه محدد لنا.
ايش البوينتس اللي بتطلع فيها؟ اذا if we want to concentrate what's the most important point اللي بدي اياها؟
ممكن نحكي عن اليلد بوينت.
yield point اللي هي differentiate between انه يصير عندك
between الالاستيك والبلاستيك deformation of any material.
100%. هسا اللي بهمني انا اي بون sustains stress that بوصل معك لليلد بوينت وبرجع للنورمال بون. beyond that بصير في البلاستيك ديفورميشن. هسا البلاستيك ديفورميشن اذا وصل انه الريموديلينج كاباسيتي cannot exceed او sustain الستريس ريليتد، بوصل عندنا الفيلير بوينت. فهذا في الابنورمال بون بيكون عندك الموجود. why pathological fracture occur؟ حكينا plastic deformation اللي هي not enough remodeling or abnormal micro and macro structure للبون. factor suggesting the pathological fracture. منجد.
نعم سيدي.
كيفك منجد؟ ايش في فاكتورز بتدلك انه المريض هذا باثولوجيكال؟
سيدي اول شيء بالبيشنت بروفايل في عندنا الايج اوردر ذان 50 وهون مكتوب 45 ايج، يعني اولد ايج از suggestive of pathological fracture. عندنا كمان سيدي previous pain at the site before trauma، واذا كانت اصلا minor trauma او يعني not significant trauma to cause a fracture.
مهم.
وإذا في عنده زي ما مكتوب هاي ال history of primary malignancies، إذا كان عنده other malignancies
اوكي.
we think of mets from that source.
So بنلاحظ من هاي السلايد انه most of the history will lead you انه this is a pathological fracture ولا لا، قبل ما نوصل لا اكس راي ولا لا شيء. Detailed history can lead us to define it. Is it a pathological fracture ولا لا؟ Etiology, we can categorize them into either a congenital or infectious, metabolic or neoplastic. Or other differentiation, either a correctable cause or uncorrectable cause. Correctable like renal osteodystrophy, hyperparathyroidism, osteomalacia, disuse osteoporosis. Uncorrectable, osteogenesis imperfecta, polystotic fibrous dysplasia, postmenopausal osteoporosis, Paget disease, osteoporosis, and malignancy. هسا in general rule الفرق بين correctable disease and uncorrectable disease. في correctable conditions you should treat the patient's underlying condition then treat the bone, especially when dealing with upper extremity lesions. بعكس uncorrectable conditions you treat the fractures and deal with the underlying conditions. What is common between both correctable and uncorrectable? We are dealing with a weak bone. It is predisposed to fracture or plastic deformation, and sometimes don't suspect that your fracture will heal. Some few points I would like to highlight about osteoporosis because it is the most common condition associated with a pathological fracture. Usually, the most common sites are femur, vertebra, and distal radius, and it only requires minor modification for typical fracture care. But bear in mind that it increases the risk of fracture from daily activities and low energy falls, and higher rate of metal failure because of poor anchorage of implant in the weak bone. As a fracture resistance of osteoporotic bone is a function of the third power of the third mineral density. The bone mineral density is an important subject to be considered while dealing with osteoporosis. It's usually measured in DEXA scan or quantitative CT scan. The use of implant, usually it should be a fixation strength to support the weight bearing. Failure of the implant in osteoporotic bone usually occurs because of loss of fixation rather than breakage of the implant. هاي النقطة اللي بدي أحكيها السكرو fixation strength is highly dependent on the cortical thickness. كل 1 millimeter loss of cortical thickness can result in 50% decrease in the strength of screw fixation. That's why in dealing with osteoporotic fracture, always aim for bicortical fixation. بعكس young patients. Young patients ممكن إنك to deal with them with a unicortical fixation. A bicortical fixed angle locking screws in thin cortical bone improves the ability of plate to resist loading, but may increase the risk of periprosthetic fracture in bending. And it is often not possible for elderly patient to limit load post-operatively. فusually إذا في عندك أنت old age sustained the hip fracture, usually ما بيمشوا non-weight bearing إلا ما يدعس إلا ما يحط weight bearing. فusually your fixation should be rigid enough. What's the minimum bone mineral density for fixation of failure? من هاي الباراجراف بتلاحظ إنه المينيمال bone density في البروكسيمال femur أعلى واحدة فيهم. you should have a minimum bone density for your fixation not to go to end with failure. And fixation strategies that emphasize the placement of screws, usually in the strongest trabecular bone, results in superior biomechanical study. These are mostly applicable in neck of femurs and proximal humerus fractures. Usually your screws التارجت تبعهم بيكون الانفيريور in neck of femurs. As an approach, starting by the approach. مين معانا من الشباب؟ جريس معانا؟
معاك سيدي يعطيك العافية.
ايش في الهيستوري اشياء ممكن بدك you will encounter or you will discuss with the patient when taking the history?
سيدي نبلش بالبيشنت بروفايل، الايج اوف ذا بيشنت and ممكن برضو يعني شو يعني شو وظيفته. في بعض الوركرز سبيسيفيك لهم سبيسيفيك تيومرز associated with ممكن كمان بنفس البين كاركترستيك اوف بين من ناحيه الانست الكاركتر، حتى الفراكتشر نفسه اذا كان التروما الاسوشيتد بالفراكتشر. ستارتنج برضه كمان مع البيشنت نفسه الميديكال هيستوري تاعه، اذا الفاميلي هيستوري، اذا في عندهم مالجنسيز رانينج ان فاميلي.
100% زي ما حكى جيريس تقريبا هو غطى اغلب الاشياء. الايج كثير مهم، هسه راح نتطرق له، كثير مهم. السكس كمان مهم. البين ات ريست هاي بدلك انه is a pathological fracture. If the patient has underlying any diseases, any medication, constitutional symptoms, a previous exposure تبعه toxic exposure or history of irradiation، هذول كلهم بالهاي. Why the age is important? Because it can label us into many categories. If we want to categorize them from 0 to 10 or 10 to 20, 20 to 40, 40, and all ages. In dealing with pathological fracture, you should keep in mind that infection is one of the causes. So don't forget infection. Infection can affect any age and can present in any age group. But like in 20 to 40, if you have a lesion, it might be a giant cell tumor. Each age has each specific differential diagnosis. Physical examination, you should do a thorough physical examination, head to toe examination, and search for any other possibility. Neurovascular examination for the involved limb, and search for lymphadenopathy when suspecting a tumor. And if a patient history entitles any chances of breast, prostate, or lung, or thyroid, or whatsoever, detailed history for that region should be done. What about laboratory studies? مين معنا من الشباب؟ هزايمة معنا؟
سيدي كيفك؟
كيفك هزايمة؟
يعطيك العافية، كيف أموركم؟
الله يسعدك يا رب. هزايمة بالنسبة لللاب studies when dealing with these patients إيش أشياء بتطلب؟
يعني أنت كاتبهم أصلا سيدي.
أنا
يعني
كاتبهم.
سيدي.
هسا سي بي سي أنيميا، وين ممكن
يس.
نشوف هالأنيميا؟ أنيميا إذا we are dealing usually بدك تشوفها you suspect a multiple myeloma can present with anemia. Chronic diseases can present with anemia. الكدني function
معظم الكرونيك ديزيز.
yes. kidney function test نفس الشيء. Multiple myeloma can present with acute renal failure. ESR CRP liver
Yes.
function test. Thank you.
يا سيدي.
The parathyroid hormone is a paramount. Many patients with a hyperparathyroidism can present with a pathological fraction. This might be their first presentation. Albumin level, calcium, phosphorus, alkaline phosphatase for bone activity, urine analysis, and serum urine protein electrophoresis for Benz-Jones proteins. As a specific tumor markers like thyroid function test, CEA, CA125, prostate specific antigen, CA1513 for breast, and CA1919 for pancreatic tumor. These should be not done routinely, but in suspected patients with specific diseases. About the disorders producing osteopenia, أي مريض بيجيك راح تطلب له سيرم كالسيوم، سيرم phosphorus. If we see this table, we can see that osteoporosis have a normal labs. You will not see anything abnormal. And in multiple myeloma also, you have a normal labs regarding these things. So it's worth it to take a look at this table and memorize it. About imaging studies. When dealing with imaging studies, it should be a proper image, AP, lateral, and joint above and joint below. Ask yourself 4 questions. Where is the lesion? What is the lesion doing to the bone? And what is the bone doing to the lesion? And what are the clues to the tissue type within the lesion? Usually it should be a systematic approach. Location, pattern of bone destruction, visible tumor matrix or not, periosteal reaction, and soft tissue component. If we want to say, where is the lesion? Is it in the diaphysis, metaphysis, or epiphysis? This can gives us a very clue about what we are dealing of in patient under 30 or over 30 years of age. What is the lesion doing to the bone? Is it an osteolytic or osteoblastic or a mixed? This also can give us a clue. What is the bone doing to the lesion? Is it making any expansion to the bone? Is it causing periosteal reaction? Is it causing calcification or what? And what are the clues of the tissue type within the lesion? Are they calcification or ossification? There's a difference between the calcification and ossification. When an osteolytic or osteoblastic lesion is noted in otherwise normal bone, the process is mostly neoplastic origin. Continuing our investigation, patient with suspected pathological fracture should undergo chest, abdomen, pelvic CT for staging workup, and MRI for a detailed study of the involved lesion and soft tissue component if present, and if the patient is undergoing a chemotherapy response to the chemotherapy or whatsoever. About the nuclear medicine studies, usually we use two studies: technetium bone scintigraphy, which is a bone isotope scan, or PET scan. And usually PET scan superior to bone scan in identifying lymphoma or lung cancer. And in bone isotope scan, multiple myeloma, renal cell carcinoma are falsely negative on bone scan. This is a diagram showing a CT scan or PET scan or PET CT scan. And this is another one showing the difference between CT scan alone or PET CT scan. What about selective arterial embolization? Standard angiogram, usually it's useful in embolizing feeding tumor vessels, especially when dealing with high vascular lesion, and usually they are encountered in renal cell carcinoma, some cases of multiple myeloma, and metastatic thyroid cancer, either as a definitive or adjuvant treatment before surgery. This is a diagram show X-ray and fluoro shows how hypervascular renal cell carcinoma can be. And if not embolizing the renal cell carcinoma before surgery, the patient might bleed a huge amount of blood on the table. Here's another one, before embolization and after embolization and after cementation with fixation. The biopsy. El biopsy, if we don't reach a diagnosis after all these, we should do or consider a biopsy. Solitary bone lesion in a patient with or without a history of cancer should be biopsied to obtain an accurate diagnosis. And patient older than 40 years of age with a pathological fracture upon trivial trauma should be labeled as METS until proven otherwise. Usually if the patient has a remote history of cancer, يعني patient كان عندها مثلا breast cancer 5 or 10 years ago, وإجت بنيو pathological fracture, it should not be labeled as metastatic. You should stage her from A to Z and all the laboratory studies, and even might need a biopsy to omit the primary sarcoma. About the biopsy, it's either fine needle aspiration, not frequently used in our practice, or true cuts, which is commonly used, and it might give you a diagnosis in up to 90% of the cases, or eventually an open biopsy. Open biopsy, when dealing with it, stick to the biopsy taking principle which was discussed, and always take a cultures, and frozen section can be used when taking the biopsy. This is a summary for comprehensive evaluation of a patient with a pathological fracture or impending fracture. All the things that we discussed are written. When dealing with a pathological fracture, is there any known malignancy or no malignancy? If there is a known malignancy, is there a remote history of cancer? Do your labs investigations and then a biopsy. If under current treatment, treat specific to the lesion. The same thing if no known malignancy, you should stage your patient, do all the labs, all the MRIs and CT scan, then discuss the patient, discuss the case. Is it a resectable disease or single site? You should go for a biopsy. If it is a multiple lesion, treat according to the lesion site. Fractures through primary benign bone tumor. Fortunately, most of these cases are seen in children and young adults, and mostly tumors gradually enlarge until the patient reaches a skeletal maturity and resolve or become inactive when they grow up. Most cases can be treated non-operatively until the fracture heals, but there are limited or some indications for surgical treatment. Unacceptable deformity in a cast, open fracture, fracture non-union, aggressive lesions such as dealing with giant cell tumor, or any lesion in the proximal femur. Don't underestimate, please, lesions in the proximal femur. If you leave them, they eventually break, like dealing with a unicameral bone cyst in proximal humerus, treated conservatively, but treating a unicameral bone cyst in proximal femur, it should be treated surgically. In treating aneurysmal bone cyst, you should always take a biopsy because telangiectatic osteosarcoma can have the same presentation. Here's an algorithm for a pathological fracture in pediatric age of group. If plain radiographs identify this lesion as a benign appearance and no need to fix, let it heal, it will heal by itself. If it need to be fixed during surgery, you should obtain a biopsy and fix the infection. If the plain radiograph shows aggressive characteristic, obtain MRI and do all the staging work up for the patient. And if the MRI is not inclusive, you should go for a biopsy and definitive surgery later on. About impending pathological fracture, we all know the Merrill criteria. Merrill criteria defines اللي هو according to the site, البين, الليجن والsize. Maximum score is 12 and minimum score اللي هو بده يكون 4. الكت اوف بوينت تبعنا هو 7 8 9. less than 7 go for radiation. 8 اللي هي بدها تكون questionable. Some go for radiation, some go for surgery. But above 8, always go for surgical fixation. And there's a new modality for or criteria, which is CT-based structural rigidity analysis for predicting a pathological fracture. So benefits of prophylactic fixation, stabilization of an impending fracture. First of all, shorter hospitalization, discharge to home more likely, immediate pain relief, faster and less complicated surgery, less blood loss, quick to return to premorbid function, and improved survival. Fewer hardware complication. Fracture risk is greatest during surgical positioning and preparation and draping. So the risk will be present until you fix your patient. About the treatment option of metastatic pathological fractures. Usually, any patient with a metastatic pathological fracture, don't label him as a dying patient. They usually tend to live longer with the new modalities and advances in systemic treatment. Improve the quality of remaining life. Usually, they require multidisciplinary care. Nutrition is a particular concern. They have a high susceptibility for embolic event and liable for infection. If we see from this, the most common metastatic lesions are involving the spine. The second lesion area is the proximal femur. About the metastatic load and the length of survival, this shows the patient with only bone metastatic or with visceral and non-visceral metastatic. Patient with single or with bone metastatic only usually tend to live longer than patient with visceral and non-visceral metastatic. About the mean survival of tumor histology in patients treated with metastatic, you can see that survival might reach up to 26 months in patients with thyroid cancer metastatic to the spine, and as minimum as 6 months in patient with a lung cancer metastatic to spine. Here's also and patient with different cancers, and the median survival for them, it might reach up to 54 months or 48 months in thyroid cancers. What about N-telepeptide of type 1 collagen? Usually it is a bone marker of skeletal metastasis. Elevated levels indicate that there is a skeletal-related events, and usually it is a prognostic factor. A patient with high NTX usually have a shorter survival rate. Skeletal-related events include a pathological fracture, spinal cord compression, bone pain, and hypercalcemia. Usually, generally speaking, in treating metastatic pathological fracture, non-operative or operative. Non-operative include bracing. It is limited for patient with life expectancies less than 6 weeks, severe comorbidities, small lesions, upper limb more than lower limb, and usually bone it might or might not heal. Usually the functional bracing is an art, and from this book we can see that it's mostly applicable for tibia, humerus, and ulna. About the medication, two categories, either biphosphonate or denosumab. The biphosphonate, it has two groups, either nitrogen, non-nitrogen containing or nitrogen containing. The most commonly used is the nitrogen containing. They have different mechanism of action. Usually it might induce either osteoclast apoptosis or disruption of intracellular signaling, indicating inactive osteoclast. And the denosumab, it acts through the Rankel pathway. It causes activation and maturation inhibition. The biphosphonate, it is one of the pharmaceuticals treatment that assist in the prevention of a pathological fracture for patients with bone metastatic. Zoledronic acid, which was shown to be effectively to decrease the rate of skeletal-related events, and biphosphonate is known as a mainstay pharmaceutical agent in decreasing the risk of pathological fracture skeletal-related events, and it even might normalize the level of NTX. Because these drugs are retained in the bone, they usually characteristically have a half-life spanning multiple years and may have effect lasting for years after administration. And once the patient is labeled with metastatic, he should be treated with biphosphonate. But bear in mind that there are some adverse effects, including atypical fractures and jaw necrosis. Here's an X-ray for a patient with who is taking biphosphonate, and we can see on the arrow that there is a stress fracture treated by prophylactic fixation using a nail. In patient with atypical fracture, usually they have a pre-existing stress fracture, and usually the pain always precedes the fracture. So patients taking biphosphonate and complain of femur fracture, consider them pathological fracture until proven otherwise, or atypical fractures. Here's another X-ray, shows a patient with atypical fracture involving the left side, and on taking imaging after surgical hemiarthroplasty was done for the contralateral side. A stress fracture was seen on the right side and treated with a total hip. About the denosumab, it's a fully human monoclonal antibodies against Rankel. It is a key cytokine in recruiting osteoclast for bone resorption, and usually it binds to Rankel, which inhibits osteoclast maturation and activation. Here's a diagram shows how the Rankel works when it's contacted with the ranks, and it causes osteoclast stimulation, and when giving the denosumab, it causes osteoclast inhibition. Here's another one showing the denosumab and biphosphonate and their mechanism of action as described previously. In most comparisons, usually denosumab is more effective than biphosphonate, except in multiple myeloma. About radiation therapy, External beam radiation, it is most common treatment used for palliation of the bone metastasis. Usually it is used to treat the pain. And studies have shown that external beam radiation provides relief in patients with metastatic bone disease. Local radiation therapy typically result in pain relief in over 80 patients with bone metastasis and complete pain relief in 50 to 60% of cases. And retrospective studies have shown that post-operative radiation improves limb function, decrease the rate of second orthopedic procedure. Radiation can usually begin 2 weeks after the surgical procedure. Radiofrequency ablation and cryoablation, not that commonly used in orthopedic, but still some centers use them. Usually it is use a probe that directly at the lesion site, and with heat generation might lead to kill the metastatic cells. Recent study for patient with pelvic and sacral metastasis treated with radiofrequency ablation showed clinical benefits with significant pain relief in 95% of the patients. Here's a diagram shows how it is done, and another one uses the cryoablation, which is again the opposite for radiofrequency ablation. About operative treatment, there are some rules in treating these fractures. Usually, maximize pain control should be the primary goal. Construct should provide immediate stability and allow full weight bearing, durable enough to last for the increased total lifespan of the patient with metastatic bone disease. In most patients, physicians should avoid fixation method that requires bone healing, porous ingrowth, and bone grafting. Nail are always superior to the plate, and intramedullary devices or modular prosthesis provides a more definitive stability. And always assume that it will be his final surgeries. There is no rule for revision cases. For femoral region, historically a reconstruction nail used to stabilize the femoral neck, even if no lesions is present at the time of surgery. نرجع نحكي على post operative radiation, increases the chances of achieving a normal function and overall decrease in failure rate. What about polymethyl methacrylate اللي هو bone cement? It provides immediate stability following surgeries, easily applicable to fill the effect, provide immediate rigidity, increase the strength of fixation, usually generates exothermic reaction. It might induce local tumor necrosis and does not affect the use of a therapeutic radiation. من هاي الصورة بتدلني على how to treat patients either with a humerus, radius, ulna, whatsoever. اللي بدي ايدك تفرق لي منه انه is it a proximal or diaphysial or distal. Usually near the joint, do we have a good bone stock ولا ما في عندي bone stock؟ إذا I have a good bone stock, it is amenable for plate or nail fixation. If I don't have a bone stock, usually we go for replacement, either shoulder or elbow or whatsoever from the part of the body. Some highlights of the point concerning proximal femur, especially in the neck of femur fractures, there's no rule for fixation. Always replace and cemented replacement in treating these patients. This is an algorithm for the upper extremity lesions. Does the patient have a history of malignancy? If no, stage and biopsy. If yes, is it an impending fracture or a pathological fracture? According to the life expectancy to the patient, if he doesn't have life expectancy less than 6 weeks, usually treat him in conservative pattern, either a fracture or impending fracture. But if it is unstable and bone loss, lifespan more than 6 weeks with a good performance status, surgery should be indicated. It differs according to the location. Is it a humerus or a hand or a forearm or wrist? In this one, we can see a humerus. It is a proximal or diaphysial or distal. Anything near the joint, if we have a good bone stock, treat with plate and fixation or nail. If you don't have a good bone stock, treat with replacement. A special consideration concerning the proximal part. according to the tuberosities. If they are intact, cemented hemiarthroplasty would be sufficient. But if they are not, usually you will need endoprosthesis. And diaphysial, always aim for either plates regarding the humerus or a nail, and always nail are superior with augmentation of bone cement. Here's another one just to elaborate about the things that we talked about. You can go over them briefly. Concerning some points about lower extremity lesions, usually pathological fracture of femoral head and neck rarely heal, and they are progressive disease. So these patients should be treated with a cemented replacement prosthesis. And in femur, always nail are superior to plates. Femur fracture, usually put and insert your largest diameter because the device will be a load-bearing device, and fracture usually does not unite. And in distal lesions, retrograde nail should be not your first option because it has a potential for seeding into the knee joint, while failing also to provide fixation of the femoral neck and epicondylar region. The most common complications: tumor progression with resultant hardware failure, cardiopulmonary compromise, hypercoagulable state, and fat emboli. Concerning pelvic and stabulum, we will not talk in deep about them, but because many metastatic bone disease to them, many bone metastases or pathological fractures occur in the bony pelvis, does not affect the weight-bearing area, so they do not require surgery. في عنا شيء بنسميه استابيلوبلاستي زي الفرتبروبلاستي في spine. في something استابيلوبلاستي under image guidance. You insert the bone cement in the affected lesion to permit the patient for weight being as tolerated. بدي تعرف كلمتين عن الهارينغتون classification اللي هو used to treat used to classify the lesion and treat accordingly. Usually they are 4 grade, starting from disruption of the lateral cortex with intact superior and medial wall to pelvic discontinuity, and treat accordingly. Here's another diagram showing the Harrington classification with its modalities of treatment, and another X-ray shows a patient with a metastatic bone disease treated with reconstruction and total hip with cage. One of the most common complications you should encounter in patient with metastatic bone disease is hypercalcemia. Hypercalcemia has some symptoms and signs. There are many, and you should be alert in dealing with these patient because it has a high morbidity and mortality for the patient. The symptoms can be fatigue or lethargy, confusion, thirst, muscle pain, abdominal pain, nausea or vomiting, and etc. If we want to categorize them: constitutional symptom, weakness, fatigue, anorexia; CNS symptoms, drowsiness, lethargy, altered mental status, and stupor or coma; cardiac, they have a short QT interval, and etc. according to the rest. It is usually the most common complication in adult osseous metastasis. Usually hypercalcemia is not usually the presenting sign of malignancy, but it has a poor prognosis for a patient. And as many as 60% of patients with hypercalcemia will survive less than 3 months, and only 20% will be alive at 1 year. Treatment usually by hydration, loop diuretics, and biphosphonate. Any patient with a cortical lesion in an adult more than 40 years is usually metastatic, and most commonly usually from lung origin. And any metastatic lesion distal to the elbow or a knee joint, usually think of lung origin. And patients older than 40 years of age with a pathological fracture upon trivial trauma should be labeled as metastasis until proven otherwise. Take-home messages. It is important that all orthopedic surgeons have a basic understanding of the principle involved in the care of a pathological fracture, so they are well recognized. Appropriate treatment is initiated. Pathological fracture through a primary malignant bone tumor is treated much differently than a fracture through a metastatic lesion. And thank you, شباب. في حد عنده أي أسئلة؟
يعطيك العافيه سيدي.
جري صح؟
سيدي. سيدي بدي اسالك عن الباثولوجيكال فراكتشرز اللي unacceptable alignment و need surgery.
Yes.
And الاكس راي looks benign.
Yes.
هلا بالسيرجري بس نعمل بيوبسي وبنعمل فيكسيشن، البيوبسي is enough ولا we also manage the lesion، يعني نعملها كوريتاج ولا بس خلص بيوبسي؟
Nice question, Jarius. According to the lesion, if we are dealing like with a unicameral bone cyst involving the proximal femur, usually they might need the graft. But if it is not, usually it does not. إذا تعاملنا مع lesion like non-ossifying fibroma, don't touch it. Just do your fixation and it will go ahead. According to the lesion, ABCs, you should tackle the lesion. And فبتختلف معك حسب الليجن. Some lesions you should tackle the lesions, and some lesions you should only do your fixations. The most important in dealing with these اللي هم non-ossifying fibroma, don't touch them. Just do your fixation. Unicameral bone cyst, if it was a huge and it requires bone graft for stability, yes. وصلت جريس؟ واصل المعلومة؟
Yes sir.
اوكي.
سيدي كمان سؤال بالنسبه للباثولوجيكال فراكتشر لبيشنت عنده ميتس والبيشنت اوريدي اون bisphosphonate.
Yes.
Should we stop the bisphosphonate until the fracture here or we continue the treatment?
هسه هاي عليها الديبي. هسه الدينوسوماب والبايفوسفونات it is really يعني treated في المالجنسي or metastatic disease usually to prevent skeletal related events. هسه you should outline your results. إذا I'm dealing with endoprosthesis or replacement, keep giving him the biphosphonate. If I'm dealing with fracture, don't assume that your patient will heal. Remove the bone, the diseased bone, and apply bone cement and keep the patient on biphosphonate to prevent other areas from going into pathological fractures.
Thank you sir.
إذا عندي area weak استبدلها ببون سمنت لأنه don't assume that your patient will heal.
Okay.
Other questions?
دكتور محمود يعطيك العافية.
هلا سيف. هلا والله
سيدي، بس بدي أسأل بالنسبة عشان البيوبسي هسه كترو كت بيوبسي أو open excisional biopsy versus CT guided.
Yes.
Which more specific or sensitive يعني for diagnosis?
For diagnosis, always superior هي open biopsy. You see the lesion, you encounter it, you take a good representative sample. بس true cut biopsy سواء CT guided ولا local guided, it might give you up to a 90%. المشكلة بالCT guided biopsy sometimes الراديولوجي ما بيكون يعني متعود على taking a biopsy زي السيرجن، فأحيانا it will be inferior. But in literature, a true cut biopsy, either CT guided or without guidance, might reach up to 90 or higher %. Always start with the true cut biopsy, then go for open biopsies in non-amenable cases.
Thank you.
You're welcome. Any other questions? معلومة، شيء استفسار؟ طيب اللي بيطلع عنده أي استفسار حاب يسأل أي شيء بيقدر يبعث دايركتلي لإلي we will contact him إن شاء الله.
يعطيك العافية سيدي على المحاضرة. شكرا جزيلا.
شكرا.
يعطيك سيدي.
شكرا لكم.
هلا سيدي.